Everybody hear me okay?
Yep.
Okay, for those online, if you have questions, just send it to chat and channel Ask Me, and then we'll go through. So for those that don't know me, my name is John RICKELMAN. I was previously the medical director of the ICU. I stepped away from that position for a variety of reasons which we won't go into. But I'm working part-time now, working 1 week a month at bedside. My other job, though, is working with Cerebell. And so one of the what we're going to talk about today is non-convulsive status and some of its burden and implications in the ICU. I went to work for that company for a variety of reasons, one of which was this is just a very interesting technological area for me. Was never taught this in training. I've been in the job 20 years, and we never were emphasized to worry about EEGs other than cold neurology. As we'll go into, and we look at the patient populations, the people we see, with a couple case presentations, we probably should have been doing this far sooner. I look back over my career and look at the patients that I've taken care of, and the delay between when I recognized there was a problem and when we finally got instituted therapy. There was a natural delay just by virtue of technology. And the device like Cerebell and other devices that are out there, I think improve that. And I'll show you again why we need to even consider this. And so I call it a wolf in sheep's clothing because non-convulsive status means they're not convulsing. So what are they doing? They're laying there. We're all happy when they're just laying there, not doing something, right? They've been jacking around all day. You've been worrying about dealing with something, whatever it was with that patient, and finally they're calm. You're like, oh, thank God, they're finally calm. Or they present to the hospital in a relatively calm state. What that may mean, though, it still means there may be something else going on. That's what we're going to discuss. So just for disclosures, I am an intensivist here, but Blessing isn't necessarily sponsoring this. I'm not presenting this honestly as a Blessing employee as much as I am as a Cerebell employee. There's some conflict of interest. Obviously, I want to make sure it's clear, but please understand from me and people that I've worked with will tell you, if it's not in the science, I'm not going to present it. I'm not going to brandbeat you about Cerebell. This is more about what the value of EEG in our diagnosis is. And why am I bringing this to you from specifically as nursing? Obviously, you see these patients first. Whether they're rolling into the ER, whether you're seeing them at bedside, whether you're up in the ICU, doesn't matter. Most of the time, you're the ones that are recognizing this changing condition. Obviously, if they present to the ER, altered mental status, that's one population. Everyone knows what they're presenting with. But invariably, it's going to be you working shift to shift or transitioning from shift to shift, seeing that change in that patient's condition. And the sooner you recognize that there may be another issue, the sooner we can institute evaluation and therapy. So from a literature standpoint, again, I got out of fellowship back in 2003. Yes, that's quite a few years ago. Reality, though, was we just didn't look at this. I mean, I worked in a surgical intensive care unit. We saw head trauma all the time. Neurology was involved, but we let them do whatever they did. We weren't the ones necessarily evaluating these things or pulling these things to bedside quickly. Literature has exploded mainly because of continuous EEG. There are more articles out there and more studies that are being done with using continuous EEG in the average ICU population. That also extends into the floor. It also extends into the ER. That we are looking at these patients that we think are altered for whatever their underlying problem is. The question is, how is the brain manifesting? How is the brain reacting to that, whatever that injury may be? Whether you're talking direct neurologic injury, metabolic injury, drug overdose, whatever that may be. How is the brain responding to that? And obviously, you can see literature has exploded because of that. A lot of the things that I'm going to present here, I have learned honestly over the past year. This is not something that was inherent in my knowledge base. As I began working with industry and reevaluating what was the implications of what EEG may be for the average population, I was amazed by how many patients, pretty much every one of our patients that present to the hospital, have some value in having EEGs as a part of their management. The problem is technologically, it's been a problem. The challenge, having a tech. You've seen the hairstyle they have to instill on these people. The ability to actually evaluate these people like we're doing telemetry, it just hasn't been there. And I think we're still not there, but we're getting closer. Indications for emergent EEG, these three buckets, as they'll discuss, really pretty much cross all of our patient populations. The post-cardiac arrest patient, without fail. That was one of the reasons why I got involved with this device in the first place when I came over for medical directorship, was I knew that was a limitation that we had here, the ability to evaluate these people routinely. It's a level 1 recommendation through the AHA that any patient that presents comatose should be evaluated with an EEG as part of their overall management. That is not a one-time and one and done. That is, as the progress over the first probably 24, 48 to 72 hours, the brain is going through changes and it should be evaluated without question. That's the second group. The third group, which is the obvious seizure patient population. And I'll show you at least in one report. Convulsive seizure patients, some of us have seen them, most of us probably have. You treat them with Ativan, they stop convulsing. Have they stopped seizing? No, 50% of those people are probably still seizing. There's no other way to know without monitoring those people. Would you ever treat VTAC, for instance, without monitoring? AFib, RVR? No, of course not. To understand that your therapy potentially worked or didn't work, you got to monitor it for effect. And in this patient population, the same thing applied. The big one, though, I think, is the first group, and that's the altermental patient. Well, who is that? Everyone that shows up. Laura was talking about sepsis, the septic population. We used to attribute the altermental status as just sort of par for the course. Crazy grandma comes in from the nursing home, seeing pink elephants. It's urinary tract infection. You treat it. She comes around. She's back to normal. But then there were those that didn't. There are those that either progressed to need intubation. There are those that progressed in some fashion, and not always the shocky patient. Right? Obviously, in the ICU, we tend to see the septic shock, respiratory failure, the more extreme patient populations. But those that go to the floor, they may not be in shock, but they are significantly altered. And in a series of studies that have been done, even small alteration in their mentation actually increases mortality. So it's not really par for the course. It is a predictor of their worst outcome. We just thought, at least I guess I should say over my career, I just thought that was just part of it. They either would come around or they wouldn't. But to recognize that maybe something else going on, obviously, is important. This is a nice review, 2022. If you're writing notes, I would encourage you to limit what these are here. I'll give you these resources. So if you just want to listen, you're welcome to. But I'm happy to give you all these resources. This goes over what to do in the ICU. It goes over these patients. And it recognizes, too, that only 37% of our patients probably actually get evaluated. So when you look at all the things that we do to our patients, which is a lot, we very rarely evaluate the brain actively. We evaluate it structurally. We'll do a CT scan at the drop of a hat. But to evaluate it physiologically, to actually see what it may or may not be doing actively, we just don't do. Or we call neurology, and then later, time and time, before it finally gets done. And so when you think of our patients and the ones that you have seen, by the time neurology gets involved in the case and the delay of when things are otherwise accomplished, you can see where there may be room for improvement, obviously. How do these patients look? Like everyone we have in the hospital. Right? If they're comatose, that's easy. If they're unresponsive, that's low-hanging fruit. That's the easy population that we go after, right? But they're confused. Who's that? Well, everybody. Well, what does that confusion mean? We're not talking that they're a little disoriented as to the time and place, or they kind of can be reoriented. We're talking people that just don't function. They're not focused. They're delirious. They meet other criteria we'd otherwise would think. Lethargy. What would lethargy look like? We're not talking that they're sleeping, they wake up and they say, yeah, I'd like to have eggs for breakfast, and they fall back asleep. These are the people that are GCSs in the 10 range, 12 range, the RAS scores of -3s. Those that we either are coming off of sedation and not waking up, or those that are on no sedation and aren't really awake either, despite the therapies that we otherwise do. And what do we usually think? Well, they come in, they're shocky or they're septic, we'll resuscitate them. It's an hour, 2, 3, 4 hours later, they're still not coming around. That's the patient we're talking about. Really, probably within an hour of resuscitation, they should wake up. Those that have been in shock for a while, when you get the MAP to the right place, they're more alert, and it can completely change their mentation. Those that have seen the resuscitation on the floors, or maybe you're not using pressors, again, once you get cross that certain line, now they're like, yeah, I still feel kind of worn out. Yeah, I like some Jello. Those are the people we're talking about. We're talking about the ones that aren't doing that aren't functioning for you, that aren't following commands, the ones that you actually stand there and actually count their respirations. Not the ones that are 20, that everyone's 20, the ones that you're like, what? Yeah, exactly. You're like, holy crap, they're breathing 12. I should be worried. No, that's normal. Yeah, but it doesn't matter. You were concerned enough to look at them and sit there and watch them. That's the person you're concerned about. That's the person you're wondering about. So why is this important? And these are older trials, but every trial I found to date refers to these. And subsequently, we'll recommend or recognize that time is of the essence. And so if a person is actively seizing, how fast do you have to get to them? 30 minutes. So if 30 minutes is the time you have to get to them, why is there a 4-hour delay? Why is there an 8-hour delay? Why is there any delay? This is no different than really VTAC. The best analogy I can think of is any arrhythmia of the head, but in specific, or of the heart, specifically VTAC is probably the best example. Non-sustained VTAC, which could be short runs of seizures, if you will. You treat the underlying problem, maybe that's going to go away. they have a sustained run of VTAC, that's the person who's going to go out on you. They may still have a pulse, but if you don't get to it quickly, now they have no pulse. You missed the opportunity to intervene. You're never going to give them amiodarone, however, without monitoring and confirming that diagnosis. So why would the brain or why would the head be any different? Okay. If you can wait 6 days to treat this, we wouldn't be having this conversation. But you can't. You got to get to it within 30 minutes. Those that have seen seizures, and we've seen some of those patients that require 2 or 3 medications to treat, it's because we took too long to get to them. You have an 80% success if you get to them within 30 minutes. After that, it drops to 40% at about 2-hour mark. So we've seen those patients, you have, or those that have been in the job long enough, you've seen those seizures that you give them the Forvadin and they may stop convulsing, but they don't wake up. Right? They really seize and you stopped it, they should come around in some fashion. But those that haven't, you got to wonder, maybe they were still seizing and we missed that opportunity. Or that first drug maybe stopped the convulsion, but didn't necessarily stop the seizure that was otherwise ongoing. They lose their airway, they progress, and we end up intubating them. Yes, ma'am. So but how do you know? It's when you monitor. Yeah, I mean, when you look at any kind of empiricism of what we do, let's think of an AED that we use, right? We put it on a person's chest. We have a condition that prompted us to evaluate. Right? We're not just putting this on everyone that rolls in the door. There's a condition that prompts us to say, hey, my differential is this, 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 and this. How do I evaluate the differential? Why do we check a glucose? But why? Who cares? But what does hypoglycemia cause? Seizures. We have seizures. So we treat it because it can cause some other further worse derangement. It's like treating hypokalemia. It's like treating any metabolic derangement. You're not just checking because of hypoglycemia, you're checking because they have become less responsive, less interactive, altered in some fashion. And this is something we think we can treat. But what does it cause that makes them alter? Maybe it's just the glucose is low and their brain's not firing because it doesn't have enough energy. But what did it set off? We don't know. Think of any hypokalemia. We have a person that has structural heart disease, potassium drops to 3. That may not sound really low, but for that person's heart, it may be too low, and now they're having runs of PVCs. They're having bigeminy. Now they're having small, non-sustained runs of VTAC. That doesn't mean you put them on amio. It may mean you treat their potassium. God bless you, and now it's fixed. Now you never have a problem. But how do you monitor that? You still have to have some kind of follow-up monitor to know that you were successful at what you thought you did. And that's what we're talking about here again. So in terms of populations, hopefully that's big enough. Can people see that?
Yeah, we can see it.
How's that? Is that better?
Much better.
Yes, I can do that. Thanks, Megan. Is that a little bigger? Okay, so this is from a 60-90% of all the seizures that happen in the ICU, 60-90% of them are unknown. Most of them are non-convulsive. So again, when you think of our patient population, they're laying there, they're comfortable. We think they're comfortable. We're happy they're finally comfortable. They could be seizing. That doesn't mean that you sedated somebody down and you got to check everyone for seizure either. Obviously, if you sedated them on purpose and they were whatever and you had goal directed. But that being said, as you wake these people up, and I'll show you a case of mine where we woke the patient up or we turned all sedation off, she didn't wake up. And we found that she was seizing because of that. The reality is that how do you evaluate the brain's physiology is really the question. And situationally, every one of these patient populations are at risk. As we mentioned, the patient that obviously presented with convulsions, 48% of those people could still be seizing. Septic patients, 32% of those people could be seizing. And I'll talk about that patient population. We're not talking everybody here. Every one of these patients that we're putting up here are altered in some fashion. A seizure is going to alter the way the person's cognitively engaging with their environment. And that you may think, well, that's, again, seems like everyone that I'm taking care of. Well, if you have an underlying problem that you think is the cause and you treat that and they are still altered, Gotta wonder. When a patient presents with syncope to the hospital, what's one of the things that we do? We put them on telemetry for a reason. We're looking for the cause of the syncope. What are we looking for? VTAC, really, because it's the most dangerous. That doesn't mean Immobit's 2 can't be concerning, doesn't mean AFib RVR can't be concerning. But of all of them, that's the real one that we're trying to rule out or at least eliminate from part of our conversation. And maybe they're just hypovolemic, but we got to make sure that an arrhythmia is not the issue, because again, that can lead to worse potential outcomes. Obviously, any direct neurologic injury from traumatic brain injury, subarachnoid hemorrhage, post-cardiac arrest patients, again, people that you would otherwise suspect, but the one that usually gets most people eyes open is sepsis. And I wish, if Laura's listening, I'm sure she might be interested in this as well. So as I've worked through this process the past year, I really honestly, because I had not seen this in my career, I didn't know where to put this in my practice. And so I came up with this decision tree for myself. And as I've talked to people at different hospitals, the reality is in medicine, there are things that we do that are time sensitive. There are things that we do that we take time with, right? So what I jokingly call the hierarchy of bad: what's going to kill you now, what's going to kill you in an hour, what's going to kill you in a day, what's going to kill you in a week. What is our job in the hospital? It's what's going to kill you in an hour, what's going to kill you in a day. That's what we're really looking for. And once those things have been eliminated, then we move on to other things. Otherwise, we're not going to worry about the long-term management of their diabetes in the hospital, for instance. Yes, we're concerned about it. Yes, it's a player of concern of what we're dealing with, but we're going to deal with the glucose of 500, get it under control, and then long-term, they're going to deal with that different process. Seizures are a little bit different, obviously. The brain is in its own version of VTAC. You got to stop it. You got to stop it now. In some patient populations, it's going to have more damage than in others. An alcohol detox patient, for instance, if they have one seizure because they're detoxing and we treat their detox and that never comes back, the likelihood of them having a long-term problem is probably a lot less than, say, a septic patient, for instance. When you saw those cases, that girl's actually doing pretty good. There are plenty of patients that have made it through septic shock. They're dead within 3 years. That literature is from 2020. That's not just a fallacy. A lot of these people are going to nursing homes. Why? Neurocognitive defects. Where is that coming from? Sepsis is causing some sort of neurologic injury in some fashion. We're not talking necessarily meningitis. We're talking the inflammation, the hypoxia, the anoxia, the otherwise lack of delivery, changes in autoregulation, inflammation. All those things can cause injury to the head, set the head up for some sort of injury. And I'll show you more studies. To that end, though, when you look at all of our patients, obviously ABCs are top. I really don't care. Shannon? I don't know what I did either. We're going to get something else here. I don't know what you have on your computer here, Shannon, but this is some weird stuff.
Well, it didn't work well.
That's right. We'll start there. So again, ABCs are priority, right? If they're oxygen levels 30, you got to take care of that. I don't really care if you're seizing, but hypoxia can cause seizures. So the subsequent injury of all the things that we're dealing with are what we're looking for, what we're chasing. After you fix that, we do CT scans on everyone to alter the drop of a hat. Why do we do CT scans? Check for injury, specifically what? Say it loud, say it proud. Hemorrhagic, right? That's what we're really ruling out. People will say ischemic stroke, but that we're not necessarily going to see that. If you see an ischemic stroke on CT scan, it's been a while. You're not going to be able to fix that. But if they're hemorrhaging, what percentage of CT show hemorrhage? Yeah, 10 to 15. But we will do those at the drop of a hat. It's funny how many people will balk at getting an EEG done on some patients, but we're talking about maybe 30% of that population could be potentially having a seizure, whereas things that we do normally, CT scans only yield about 15%, right? Far more expensive, far more radiation, obviously a problem to move that patient out. I wouldn't say you would preclude doing a CT scan for doing EEG. You got to do them both. We do EKGs for a reason. We're looking for malignant rhythms. We do glucose like we already talked about. It's simple, low-hanging fruit. The interesting thing about glucose, though, again, it can cause seizures. So we're trying to treat it to prevent them from having a seizure. It's one of the reasons why we treat alcohol detox the way we do. We use benzodiazepines because it's a therapy to alter and keep the brain, hopefully, from seizing. Intriguingly, in alcohol detox patients, the more they go through detox, let's say they do 3 or 4 times, the higher likely they're going to have seizures later on. So they're having alterations in their brain chemistry, alterations in their brain tissue, that they're injuring their brain over time. It could also be that some of these altered detox patients, maybe they were seizing. We treated their Ativan, they got better. Well, actually, what we were doing was treating seizures, but we don't check them because we think it's par for the course for them to get altered. Something to think about. ABGs, of course, you know, if they're altered, we're looking for hypercarbia or hypoxia, overt hypoxia that's something we need to deal with. But EEG falls in the same light. You know, all the different diagnoses down at the bottom that I mentioned and all of that populations, they can induce seizures. So if they have a head bleed, they could be seizing. How many times do we send a patient down to CT scan who subsequently decompensates in CT scan, gets intubated in CT scan, and we send it, and we sent them down because they were altered, right? So it makes you wonder. When I look back, I'm not saying all these people are going to be positive for seizure. Some of them may just have other changes, whatever it may be. But the reality is we know we've seen those cases where there's been some sort of deterioration that we can't really account for. And then you get the CT scan that's negative. Why'd they decompensate? Progressive progressive seizures that over time, even post-ictal patients will lose their airway, especially if it's ongoing. So that evaluation needs to be done, or at least needs to be considered. So just by example, this study was 2020, I think it was really just looking at timing. You know, even large hospitals, Mass General, Southwestern, UCLA, Rush, big places, lots of resources. It still took them 4 hours to get things done and evaluated. And so if we're talking 30 minutes is what you need to get to, 4 hours is just unacceptable. I doubt if we told Laura, hey, we're going to wait 4 hours to treat sepsis, that she would be excited about that. In stereo. So waiting any amount of time makes no sense. And so the faster you can get it done, the better. So whether you have Cerebell, for instance, or you don't, and you go on to another institution, just the ability to evaluate these people quickly, timely, is going to make the difference potentially. What I liked about the study more or less, though, when you look down at the bottom, this 40% versus 86% was going from empiricism, where we're treating these people blindly, to having information and treating those people with the information. You know, shifting from an AED to a bedside defibrillator where we can actually see the rhythm that we're facing changes things, right? Because if they have a non-shockable rhythm, what do they have? We don't know with an AED. When we hook them up to the machine and we can see that it's a Mobitz 2, or we can see that it's pure PEA with a normal sinus rhythm, our differential shift a little bit. If we see big peak T wave, our differential shifts a little bit. It allows us more eloquent understanding the information that we can treat the patient a little bit differently. Yeah. Yeah. Depending upon the patient. So Tracy asked the question about how long do we leave the device on, or how long do we evaluate a patient? And there was a study, which actually I don't have in the slide deck. Everybody close your eyes. I'm going to flick Tracy off. Westover, I think, was the name of the author. But he showed in 2 hours, if you evaluate a patient for 2 hours and there is no seizure activity, okay, zero. So on the device, it would be 0% seizure burden. Then I think 95%, you won't have any kind of issue in the next 48 hours to 72 hours, or 72 hours. But that's not 100%. So while you can evaluate those people, the one beauty, at least of the device, is you can evaluate them frequently. If you see any kind of irritation, so any kind of burn, that means the brain's a little bit more lit up than average. That's not the patients we're talking about. They got to be at 0%. I had a patient come from outside institution, alcohol detox, intubated for seizures, came to us, placed device, 20% seizure burden. We treated her with Ativan per our normal protocol that we had. It went to 0%. She never had any other episode. I didn't put her on any anti-seizure medications. We got her extubated by the next day. She had an underlying problem that was dealt with, treated, no other episode, right? So I think one of the problems and one of the challenges I think I've run into with most people is everyone tries to extrapolate epilepsy to seizures that we see acutely. Epilepsy is a disease. It's a structural changes in the brain that puts that person at higher risk for frequent seizures, as opposed to we may have isolated events, a hypoglycemia, an alcohol detox, a meth abuse, something like that that once that's dealt with, they may never have another problem. So it's almost like lone AFib. Just because a person has a run of AFib in the hospital doesn't mean they need to be on anticoagulation for the rest of their life, unless some reason you think it's paroxysmal. It could be very, very situational, high pressures or something like that. Take that away, you never have another problem. But again, how would you know they went into AFib without monitoring them? And then how would you know that was a lone event unless you evaluate them further? Yeah, go ahead. Good question. No. No. Thanks, Tracy. No. Susan asked, what point should we treat the burden? Let's come to that near the end. Let me get through a little bit more and we'll talk about that. The reality I would offer is it really depends on your patients. It depends on your patient population. Like in my patient's situation, she was 20%, but I had a known problem. I knew why that was the case. Of course, we CT'd her, we did all the things just to make sure, but it never happened again. How's that any different really again than AFib? When are you going to put them on amiodarone? How long are you going to continue that? And that's really the question. We'll come to that. So post-cardiac arrest, let's talk about this one patient population, because this is really the one that honestly we got to be evaluating everybody for no other reason than it's a level 1 recommendation per AHA. Why is that? Well, obviously, I jokingly will say they went through Control-Alt-Delete, their brain's rebooting. How is the cell going to respond to that? We have no idea. It doesn't matter how long they were down. Obviously, the longer they're down, the worse it's going to be. But we really don't know the person. If you're talking to a 75-year-old who's down for 5 minutes as opposed to a 24-year-old who's down for 15 minutes, what's going to happen? We don't know. We don't know what the cells are going to do. We don't know what other issues or comorbid illnesses they may otherwise have. So to that end, as these patients recover, the reason for evaluating is because, again, we don't know. The unfortunate part of all this, though, is from an outcome standpoint, we don't know either. The recommendations are we monitor everybody. Why is that? Because as the brain potentially comes around neurologically, potentially they're going to seize. And so we want to treat that. Why do you want to treat a seizure in a post-cardiac arrest patient? The brain that's broke. Well, don't assume heart attack. So it may not be a heart attack. Either way, you've lost oxygen. You've lost oxygen delivery to the brain. What is a seizure going to do in terms of the metabolic act? It's going to increase it. So why do we cool patients? We're trying to bring oxygen delivery and consumption down so they're equal, essentially. So that whatever we're providing, whether they suffered a heart attack and now their EF's 10%, or whether whatever they did, they were drowning or whatever. We're trying to make sure that delivery from the heart is matching the consumption of the brain. Any increase in metabolic demand is going to increase the consumption of the brain, and we're not going to be able to necessarily match that, right? We're not going to necessarily be able to know whether we could increase heart rate, delivery, and match whatever consumption may be. A seizure is a mass increase in oxygen consumption. That's why temperature also. That's one of the reasons why a lot of literature supporting euthermia, where the temperature is normalized, is potentially just as efficacious as making them a popsicle, right? As we're learning, maybe there's degrees of injury. This person's down for 20 minutes, that person, you may freeze them. Person that's down for 5 minutes, you just maintain euthermia. We don't know that yet. We're still trying to figure that out. And actually, I think one study I saw showed those that were in the mid-range of injury time, those did the best. If they were down for an extended period of time, cooling doesn't help because the damage is too severe already, and cooling could actually make things worse. If they are mildly injured, then cooling, there's a negative side to cooling these people, right? So we're trying to balance what's the benefit. In the case of seizure, the same thing. Most of the literature, however, when you look at the recommendations, and while they give a level 1 recommendation, which from an evidence-based standpoint is second only to God in terms of science, there's really not a lot of literature behind it. I'm still actually a little surprised why they gave a level 1 recommendation, because there's no therapeutic implications. They even make the comment in the guidelines that we're not really sure that if we institute therapy, we're going to see good outcome. This review. Oh, here's an example of a case study. For those that have not seen Cerebell, it measures seizure burden. And so you have a machine learning AI that's looking at the patterns. It's like a better version of our telemetry AI that looks at patterns and tries to delineate what may be a threat and what may not be a threat. And so in this case, they showed a significant seizure burden as high as 90%. So the patient was a post-cardiac arrest. the patient was altered, not coming around. They placed on head based on the presentation and showed there might have been a seizure. They dosed the patient with I think lorazepam or midazolam in this case, and then loaded with Keppra and took it down to 0% seizure. Okay. So one of the powers of having something like this is it allows us at bedside to actually do something instead of waiting and waiting and waiting. I remember a case, I don't remember what the case was. I just remember we had 24-hour EEG going. I think Joanne came in or someone came in and said, oh yeah, they've probably been seizing through the night. No one had notified us, even though we had EEG on the patient's head. So you did 24-hour EEG devices while they're good. They don't necessarily have alarms. They don't allow us to be able to go by the room and go, hey, I think something's happening or not. That being said, they cover more of the brain, and so they can be more specific. The purpose of this device is to allow us at bedside to recognize there's a problem and then triage that patient up to something more extensive if necessary. This review, which is really good, I would encourage you, if you're managing these patients, looks at post-cardiac arrest. That's probably the best state-of-the-art review of the topic. They do mention a study called TELSTAR, which was done last February, where they looked at anti-epileptic medications in post-cardiac arrest patients. There was no improvement in outcomes with administration of medications. The challenge with that study I would offer, though, was 15 hours of randomization. What does that mean? From presentation of the patient to when they instituted study was 15 hours. Okay. Is there anything that we manage that we can wait 15 hours to do it? I can't think of a thing. Everything that we do is about narrowing that window and getting to it quickly. Again, if you think of the patient, let's say they were seizing ongoing, I think a percentage of them were seizing when they placed the device on head, and it wasn't cerebral, it was typical EEG. That means their brain was on fire, for lack of better descriptions, for an extended period of time before they ever instituted therapy. So of course, why would there be better outcome late? In septic shock, most of the studies up until Manny Rivers' trial back in, I think, 2000, randomized around 12 hours. So these patients would present, then they would start targeting their systemic hemodynamics aggressively around 12 hours in. Damage has already been done. Once they realize you start from time zero, everything changed. While we still have a lot of work to do, the sooner the better, right? It's not like a stroke rolls in the door and they're at, 1 hour mark. You're like, hey, we got 2 more hours to wait. Let's give it some time. I want to get something to eat, and then we'll come back and TPA you. The sooner the better for everything. And you got to wonder again, now, is that going to be true? I don't know that. We just don't know. The other aspect to it, though, is evaluating someone with a seizure right at the very beginning. If they are seizing at presentation, they have worse outcomes overall. So whether the therapy works or doesn't, the impact on discussing prognosis with families, I think, is still just as powerful. And while at times we try to go after, oh, we got to fix a seizure, fixing it may not do anything. And so it may be the indication that their brain suffered that much more injury than the other person who didn't have a seizure, and their long-term risk is going to be much higher. So either way, the information is powerful. So sepsis. How do you move your? There we go. Yeah, I was trying. No, you're silly. Anyway, sepsis. So Laura should love this one, but this is a nice review from 2021. Historically, when I was first asked to start speaking for Cerebell, I only thought about post-cardiac arrest patients, honestly. That's all the patients I was thinking about. And the first thing I plugged into Google was, or Dr. Google, I should say, was sepsis and EEG. And I was floored by how much literature was out there. A study as far back as 1992, which, not to date myself too much, but I was, 3 years before I was even a med student, showed categorization of EEG in septic patients and showed significant changes in this population. But we never discussed it. It was never in our guidelines, never in something we even targeted. We targeted cerebral resuscitation in post-cardiac arrest, but we don't really talk about cerebral resuscitation in the septic patient population, right? We're all about getting their MAP to a certain level, get the antibiotics. We look at ARDS, we look at AKI, we look at shock, obviously, but what the brain's doing is not really discussed. So this review, if you get a chance, I encourage you, if you're interested in this stuff, it's very good review. So this case was a case of mine. Was a lady that presented initially with RSV developed a secondary pneumonia, had end-stage renal disease, was in the ICU on CRT, sort of waxed and waned in her mentation, but decompensated to the point that I had to intubate her. She was hypercarbonic and hypoxic. We tubed her, but we had sedation off with her within probably 24 hours. Unfortunately, I wasn't notified till the next morning that her sedation had been off for 24 hours. So we had turned it off in 18 hours later, probably, essentially, is when I walk in and someone comes up to me and says, hey, Mrs. So-and-so has her sedation off. She's not doing anything. Walk in the room, finger pinch, nothing. Maybe a RAS score -4, arguably maybe a -5. The person that was working the day is like holding Cerebral in the hand. Hey, you want to put this on her head? It's like, sure. A little proud that someone suggested to do it. Anyway, we put it on her head. She went to 100% seizure burden immediately. So for those who don't know the device, it's a circumferential band. It sends information out to the cloud. The cloud processes that information and brings it back to the device. So every 10 seconds it goes out. It's always processing on what's going on every 5-minute interval. So as it shifts forward, it is processing what percentage of that time frame in a 5-minute interval, and we're talking as it shifts by 10 seconds forward, what percentage of that is showing any kind of pattern that is concerning for seizure activity, or what they call high epileptiform findings. So that means there's a pattern that the machine's going, this looks bad, right? It's not about what it is, it just looks bad. In her case, the first 5 minutes of it on her head, she's at 100%. So that means it was continuously finding this pattern of bad. What's concerning about that? I have no idea how long she's been in this state. Luckily, I gave her 4 of Ativan at this point, and she went to 0% seizure burden. I wrote Dr. Jawan at the time, texted him and said, hey, I got a lady that just put a device on. She looked like she was seizing. Give me a holler back. He got back to me in about an hour and a half because he was in clinic. And he confirmed by looking at the portal, yep, she was likely seizing, and yep, she responded to therapy. He's sending the tech over. Right? A couple salient points I think that are important. It's a septic patient. We don't always think about that population. I had a locums with me at the time also, and I asked her if she ever seen the technology. She said no, she hadn't only been out of fellowship for 2 years. I asked her what she would have done different if we hadn't looked, and she would have done what I probably would have done 5 years ago. Hey, let's give it another day. Let sedation wear off. She's on a bunch of stuff. She's old, blah, blah, blah. Let's wait another day. Let's wait another day. How many times have we done that? How many times have we had those patients and we didn't evaluate them? Some of them may wake up. Some of them do. But then you look at post-ICU syndrome, neurocognitive injury, all that stuff that we see down the road. Like we were talking about the septic patient 6 months down the road. This is the patient still in the nursing home who can't recognize her family, blah, whatever. You got to wonder. Or like in this case, we ended up pulling on her and letting her pass. But the reality is we see these patients all the time and we send them for CT scan. We do all those other things that we otherwise have up there. And we looked at her renal numbers, for instance, they were fine. So it wasn't uremia or unlikely uremia because on CRT. So there's something else. You got to go looking. In her case, we found that she was seizing. Please understand, we place the device on. It's the small percentage of patients are going to be positive. Small percentage. And so when you do place any kind of EEG, if there is no seizure, that doesn't mean, oh, we did the wrong thing. That would be like being upset when I sent him for CT scan and I didn't see a bleed. I'm like, dang, there's no bleed, right? We're trying to rule out things that are most dangerous to that patient. The other part, obviously, though, was had been going on. She was actively 100% burdened at that time. How long has she been seizing? I don't know. You could say, well, she responded to first medication. Yeah, that's a percentage of the patients. In her case, she could have been going on much longer, or it could have been progressing over time, small runs that then turned into what one from non-sustained VTAC went into VTAC, essentially. Okay. Any questions about that? Not that I heard. General accuracy of physical exam in average patients sucks. So, not saying you couldn't find something. So, like pupillometry. Have you guys seen the pupil? I can't even say the word pupillometer. Or, yeah, maybe. Need a little bit more caffeine. Basically, the device sits over the eye, flashes light, looks at watches eye constriction. but it does it objectively. And I say that because what any one of you sees at any given time, I guarantee you can't tell me it was a millimeter that it shifted. You might say the size of it, but to be able to measure it consistently, moment to moment, day to day, it's not there. The objectivity of measuring, for instance, that device has actually been predictive of potentially having non-convulsive status from a physical exam standpoint. By definition, though, non-convulsive means there's nothing. That doesn't mean there couldn't be something. You're 100% right. If you walk and see, she didn't have eye deviation. She did respond to pain. She kind of moaned a little bit. Not moan, but at least try to wiggle a little bit. But not a lot. These patients are going to do a lot of different things. So I think the reality is there's no consistent pattern. So having the index of suspicion that that's part of the differential, I think, is the most imperative. Here's the other part to that, though. Let's say she did move. Who says she wasn't post-ictal? Like Tracy said, some of these patients, while we target, and something I realized in talking to some of the cerebral people in terms of slides, we don't talk about post-ictal states. Post-ictal states are psychosis. They can be hyperagitated. There's ample case reports of patients that were admitted to psych units, evaluated, found to have non-convulsive status, never had an active seizure, but had these episodes of hyperagitation. I know we've never seen that in the hospital, but it makes you wonder that there is a potential. We treat hyperagitation with what sometimes? Right? We have success with using Depakote in some of our patients that are hyperdelirious. Why? Were they having seizures? Is it just hyperactivity of the brain? I don't know. I can't answer that question. What I can tell you is there's ample literature, though. The brain obviously suffers something and it responds to the things that we do for a reason. So having suspected, even if you don't see it on a physical exam, we do the same thing with anything. The more you can objectify something that adds to your physical exam, the better. So whether you're using this, whether you're using ultrasound for pneumothorax, whatever. Does anyone know what the yield of chest X-ray for pneumothorax is, by the way? Sensitivity is like 40%, which is abysmal. So just something to think about when you start thinking in terms of context of technologies that we choose to use. So in sepsis, how does it happen? I can tell you in my general training over the years, until I did some of the research that I've done, when I say research, looking at the literature that's already present, the general suspect was the blood-brain barrier was not affected. At least that's how I was always trained. Unless they had CNS infection, blood-brain barrier was not affected. That is totally wrong. As I've looked through the literature, I again, never realized that. You have vasogenic edema. Vasogenic edema is swelling of the neuronal cells. There's actually a study of using hypertonic saline in patients that present with sepsis to minimize volume, actually showing improvements in GCS. That was not powered for that, so it's not really something I'm saying advocate for using, but it shows you that maybe resuscitation towards the brain is something we should think about. You have ischemic mechanisms due to impaired autoregulation. You guys know what autoregulation is? Anybody know? Autoregulation is the ability of a capillary bed to dilate and constrict based on demands and based on pressure changes. Okay? Have you guys ever seen a hypertensive emergency patient who's peeing blood, basically? Right? It's because the pressure exceeded the ability of the glomerulus to dilate, and the pressure is now causing active damage. If you take a person who's chronically hypertensive, they're able to withstand a higher pressure than, say, someone who isn't chronically. The brain's the same way. The brain's extremely sensitive to autoregulation. Why do we blow down CO2 on patients if their ICP is up? We're trying to cause vasoconstriction to decrease ICP. Changes in blood vessel dilation is intimately based on demand, as well as forward flow. So if you're pushing a big pressure forward, it will dilate to try to accommodate so it doesn't cause damage to the blood vessel, which causes inflammation. So in everywhere in the body in septic shock, autoregulation is screwed up. So capillary beds are supposed to sort of work together on demand. It doesn't happen. It gets altered. So sepsis throws all that off because it's more of a heterogeneous damage to the body as opposed to just happens this place and just happens this place. It happens every place. Okay, and every cell is different in how it responds. And the brain's the same way. So actually, in MRI studies that have been done, they show some ischemic lesions on septic patients. What does that mean? So that crazy grandma that rolls in the door, maybe she's got brain changes that we're not contemplating. And while we do our resuscitation and she still doesn't come around, maybe there's more going on than we realize. How many times have you seen a patient where your MAP is, say, 75 and they're doing great? You let it drift to 65 and now they're not as interactive. I've seen it a lot. I can't say that I have categorically focused on trying to objectify that, honestly, because 65 is the goal and we try to go to the lowest effective, whatever. But you've seen those patients that just have drifted a little less interactive than what they were. Well, 65 is the goal. So we can go, well, maybe it's not the goal. Maybe 75 should be the goal for that person, and we don't individualize it. And this is where potentially, at least in the future, EEG may be something that helps us do that, especially in the altered patient. I took care of a guy when I was over at the other hospital I worked at. I come in, they tried to resuscitate him through the course of the night. They thought it was a bowel obstruction, gave him like 5 liters of fluid, heart rate was 130, an AFib RVR. I added pressors at 8 mics and a repi. They called me into the room because he wants to die. He says he's done. He's tired of all this stuff. I said, hey, give me 2 hours, whatever, we'll fix something. Put an art line in him, hook him up to the device we were using for cardiac output. His SVR was 400. He was grossly vasodilated. I tripled his norepi, so a weight base to 25 mics for him. He went from wanting to die to making fun of my beard. Brain perfusion was the issue. We assumed certain things, but pushing his MAP a little higher made the difference. So in this study here from 2015, they actually showed that 32% of the patients presenting confused. Did anyone here work the ER? So you got a patient rolls in the door confused. Ever seen one like that? Never, right? Right, never. Only on Friday nights. And this person comes in, we think that they're just septic. We think that's the main cause. They could be seizing. Treat all the other stuff you're supposed to. They could be seizing. What always surprised me when I talk to people is everyone acts surprised they could be seizing. But why is that? Why is AKI acceptable as the sort or the form of injury that the kidney suffers, and seizure is not acceptable as the form of injury that the brain suffers? I don't know. It doesn't make any sense to me. But in this population, it could be. Intriguingly, though, seizures didn't necessarily mean they were going to die, right? At least in this study. What actually showed worse outcomes was that they had suppression. So if you were looking at their waveform and they had a very suppressed waveform, and I can't tell you what necessarily that looks like other than close to asystole in terms of brain function, that's the person who's far less interactive, who doesn't come around with fluid responsiveness, doesn't come around even with pressors. That's the person who dies. 70% mortality if they're suppressed. My question is, maybe that's the person you push the MAP up to 75. Maybe that's the person you push up the MAP up to 85. I don't know. You got to wonder that our resuscitation goals, we blanket the population, but maybe they should be more specific for individuals based on presentation. And brain monitoring has to be at least a consideration. This was the study I found first when I plugged into Google. This showed that actually patients that survive sepsis have almost 5 times risk of developing seizures long term. So like that yes. When matched for severity. And when you say they didn't have one, people don't always know they did or didn't. So if they truly had non-convulsive, people thought it was just septic encephalopathy. Maybe that was a seizure that caused injury to the brain that over time caused progressive problems. Kind of like having an MI can cause arrhythmias progressively over time. Think about the girl that we were talking about earlier in her uterus. In her case, she's lucky that she's done as well as she has. But in this, when matched for severity, those patients have worse outcomes. Okay. All of it. Yeah, well, so even just back up to what you said about oxygen delivery. Let's say oxygen delivery is low. If you're not an older person who's used to having certain depressed oxygen levels, when you look at some of our COPDers that can withstand anything, right, and they come up and they're fine. You take a younger person, who any anoxia to any of us in here, yes, I include myself, we're going to suffer more injury. You take a person who maybe is a little bit more tolerant of that, maybe they won't tolerate it, but they have other issues. They're going to have sclerosis of certain vessels. They're going to have more effect that could lead to strokes, in some cases, or even minor strokes that then damages neuronal tissue, which then sets them up for seizures later. To have post-ischemic stroke seizures is not an uncommon finding in any of those patients that we take care of. That's why getting to them as quick as possible is imperative. Why you can wait to 3 hours, it's not wait to 3 hours, it's up to 3 hours, and you can start to treat them, 4.5 in certain patients. The reality is the sooner you're stopping tissue damage that then sets them up for further problems. I put this in here because this is the most recent guidelines. There is no mention whatsoever of any kind of brain injury in this guideline. None. Doesn't talk about it even a little bit. Doesn't even suggest it, which I find interesting. It also actually under MAP says that the brain has autoregulation to adjust for based on pressures, and lower end of MAP could be 60 even. Autoregulation in sepsis doesn't exist. It changes and alters per person. So that's again a misnomer in terms of the guideline. People just haven't looked at it. I'm not saying I'm coming up with anything novel. I think the literature's there. It just was never a target, at least in the past. Well, we have, but when you look at, let's say even just Starling's literature in terms of being able to be more individualized to the patient. So the more every study that you see in terms of treatment populations is 80-20 rules. 80% of the population, 20% no one knows what to do with, and we're supposed to adjust to that. Why is that? Because our ability to monitor people. As we've gotten better at monitoring people, we adjust accordingly. So having the ability to monitor how the brain may be reacting to whatever you're doing to them is imperative. I had a patient 2 weeks ago when I was working the week with Shabir. She's 90 million years old. She's on the verge anyway. Was doing okay, more interactive. Got a dose of cefepime, goes out. Cefepime is well known to cause neurocognitive problems. Can cause seizures also. So the ability to monitor that or recognize that, be aware of that, and then subsequently make treatment. That's why it's imperative that you guys are far more astute at this than even the physicians are, because you're going to know, hey, I gave this happened. I gave this, that happened. You're going to see that change in that trend. Fentanyl, for instance. Does anyone know what one of the big side effects of fentanyl is? From serotonin syndrome. Serotonin syndrome can cause seizures, but it doesn't matter whether it can or can't. It can alter the way the brain interacts with things. It's just something you have to be aware of. Doesn't mean you shouldn't use fentanyl, just means that you're aware of it. And you evaluate when you have to, whatever that evaluation may be. I know we're running out of time. I just want to finish this up real quick because I got like 20 more slides. The biggest thing here, and I want to come to the seizure burden. The biggest thing, the rest of these studies, and again, we'll happy to send these to you, was to a patient, it's altered mental status. It's really what it comes down to. While we try to target certain patient populations, like that's something we need to really talk about, the reality is to a person, if they are altered, that's the person you need to consider evaluating. A person seizing is very rarely not altered. And alterations can vary on degree and severity. We're not looking for focal seizures. We're looking for global seizures, kind of like looking at shock. Yes, ischemia is an issue when it comes to, say, a leg or whatever, but shock is a global phenomenon that we're trying to stop because it's a global effect on organs that otherwise may not be involved. We're trying to prevent. Right? If I can stop the kidneys from suffering long-term issues, I have less issues. Same thing with the brain. If I can stop the brain from globally having a problem, then the chance of them having a better neurologic outcome is going to be better. Seizures don't necessarily mean death. That's another, I think, misnomer. Everyone thinks seizure is a bad thing. No, it's the way the brain is suffering some sort of injury. Whatever that is, find the underlying problem. Find the other problem and fix it. So whether that's a glucose, whether oxygen delivery is an issue, whether it's potassium's low, sodium's weird, whatever it is, fix it. How many times have we had these patients that were septic in renal failure, we're delaying dialysis? We think, hey, let's just see how they are tomorrow. That altered mental status patient, maybe they need it sooner. If they're awake, asking for Jello and giving you thumbs up, maybe that's the person you can wait on. But if there is any alteration or mentation, maybe that needs to be sooner rather than later. And I know we had a case even that developed seizures on the floor that had to come to the unit, got intubated, so on and so forth. Okay. So whether you have EEG or not, just simply contemplate that acute mental status has to be a little bit more risky in your mindset of what could deteriorate compared to someone who doesn't, right? What does that mean categorically for the patient? Get better at evaluating GCSs, and in combination with RAS scores. For those that don't know how to do a RAS score, I don't have it in here, look it up. It's very easy, very simple. Biggest thing is recognizing changes. How many times have you seen an order hold Ativan if patient's sleeping? Right? What does that mean to you versus what does that mean to me? RAS score helps give you delineation of what that difference is. -1 to -2 is a difference. -2 to -3 is a difference. Evaluating those people in those lines and then asking for assistance to evaluate. To the seizure burden question that was asked. So seizure burden is that percentage of time that there was a bad pattern. Okay? The way just because a person's at 20% doesn't mean that's not seizure runs. So the question I would have would be, what is their underlying problem? What has been their trend? Is there anything you can fix? So a person that has a seizure burden, let's say at 20%, like my lady, she got a dose of Ativan, everything went away. Right? We never had another problem. That was the end of it. So I didn't really worry about it as much anymore. I'm not going to load her with Keppra. I was asked to load her with Keppra. I didn't at the time because I had the ability to monitor it. She's 20 to 30%. She's a post-cardiac arrest victim. Call neurology right away. They need to look at the patient. They should probably transition to full montage anyway. Look at the patient and decide from there. And then have discussions with neurology, have discussions always with whoever your provider is, and decide what the trend is. But seeing what the trend is. But remember, that number doesn't mean they're actively having status. In terms of total percentage, you got to have really about 30 minutes of seizure activity to be considered non-convulsive status. The 5-minute rule is mainly because that's been shown once you go 5 minutes, the likelihood of them converting into non-convulsive status is much, much higher. And so it meets the criteria for non-convulsive status at that time as well. Okay? Does that answer your question? Okay. What else? Usually, well, yeah. So particular percentage of what treatment? Usually about 50%. 50. Yep. That being said, it still comes down to the patient population. Who are we talking? A post-cardiac arrest patient, or are we talking someone who's a meth abuser we just intubated, who was 50%? Now they're down to 25% before I've even had a chance to do anything. Okay. Yeah.
It all depends on.
Yeah, I mean, so the other part to the technology is the machine learning is like version 6 now. So they're continuing to hone that in. And so the more, as they get more progressive, ideally any activity means seizure activity. But I would offer that doesn't necessarily mean you need to treat it. What other things can you fix? Again, best analogy is non-sustained VTAC. You see a run a non-sustained VTAC, what are you going to do? Look for things that otherwise maybe need modified. Maybe a small dose of beta blocker, which would be like Ativan, or maybe they just need to fix their potassium, or maybe you need to fix the glucose. Have you given them thiamine? I mean, all these other little things that we need to do. The brain having a seizure is a symptom of another problem. It's not necessarily a disease. We try to, I think, act like it's a disease, and it's not. It's a symptom of something. So fix that something. So even if you do stop it, did you treat the underlying problem? And if she's a meth abuser, for instance, yeah, I mean, once that's out of her system, she may not have another problem. The challenge with medications are, you give too much, you're tubing her. What's the average dose of Ativan for a seizure? Right? Not 1, then 1, then 1, then 1. 4. Review. It is 4. No, it's been, when you look at the guidelines, it's been 4 for a long time. But you give 4 to someone who's on the verge, you're buying a 2. So it's something to keep in mind. Doesn't mean you can't do it, but that also goes back to whether other anti-epileptic medications might be worthwhile. So that's where talking to neurology as quickly as possible may be worthwhile too. I don't know, but I'm monitoring it. Yeah, but I'm monitoring it. So I've given beta blockers for non-sustained VTAC before because they were in a hypersympathetic state, whatever the problem was, and I never had another run, so I wasn't going to put them on amio just to do it. Essentially, two. I have personally, when if I see episodes, remember it's episodes, then extends the time. So if you have 0% for 2 hours, you're good. If any episodes in that, you can extend that out further. Yes. So, yeah. So the question was, if we go beyond 2 hours, when do you get neurology involved? I look at this again like any kind of arrhythmia. So the one nice thing analogously between brain and heart, it's really the same in terms of electricity. The brain has electrical primary function. Heart's driven predominantly by electricity as well. So any kind of arrhythmia in either area should tell you when you need to escalate consultation. Our job at bedside is to try to get to those things that we can deal with quickly or gather information so when specialist does come in, they have that information in front of them. Anything that narrows that window, right? How often is that the case that we have everything in front of them, and then they can make decisions as opposed to having to wait for something to get done, right? Our job at bedside is to have all that stuff as quickly as possible. You know, and like point of care ultrasound, there's plenty of times when I don't call cardiology because I can look, see if the heart otherwise looks fine. I'll wait for the regular echo to come in at some point. I don't see anything that needs emergent engagement. If I give a single dose of a beta blocker and non-sustained VTAC goes away, same thing. I get the echo, I look at the electrolytes, look for other causes that may have set that up. If the first troponin's negative, second troponin's negative, I don't bother cardiology. But anything else that escalates me to get the specialist involved, you know, that's what we're trying to get to the point where honestly, when we call them in, there's a reason to call them in, not just everyone that looks a little bit confused. Seizure burden is going to be the best in terms of information. So she was asking about the brain stethoscope. If you haven't heard that, don't ever listen to it because you'll never unhear it. Very creepy. Originally, so we had device before they had Clarity. Clarity is the AI algorithm that is evaluating the patterns. There was ample literature to show that listening to that really terrible sound could be predictive of whether they were having some irritability of some kind, but it wasn't necessarily pathognomonic for it. Clarity is actually looking at patterns. When in doubt, use Clarity. There's no reason to do brain stethoscope. My patient was a prime example. Within 5 minutes, we had the information. So once the device is on head, you have good contact, 5 minutes, you'll know. It's not enough time. You have to have 5 minutes. Yeah, so like in my patient's case, we ended up sending her for CT scan, but there's a natural delay, right? So if you know how we pick, people have been asking, when do you do it? Whenever you have the opportunity, you need 5 minutes to know. You don't want to be taking, now in her case, we had a secure airway. Do you want to take a confused, altered patient down to CT without a secure airway if they're seizing? I would say no. You'd probably want to treat her, but that doesn't preclude the need for CT. She can still have a head bleed that's causing the seizure in the first place. But now you have a far sicker person going down. I remember a lady I had, it was a COVID patient in room 7 that was altered. We were going to go to CAT scan. She decompensated before we took her down to CAT scan because there was interestingly a delay getting people to CAT scan, which is weird. I intubated her because she lost her airway. Got her downstairs. She had 2 massive bleeds, you know, in both hemispheres. And I think we had her on heparin, you know, that whole shebang for COVID. But she had a big bleed. Had we sent her down there, yeah. Now, did we check her for seizure? No, we did at that time. But she's an example of a person who was deteriorating, altered mental status, and it wasn't like she was unresponsive. She just was hard to waken. When she did waken, was not very interactive. Probably a RAS of -3, let's say. GCS probably 12. Not an intubation, but she was. You could just kind of see it deteriorating, and so we tubed her and then got her down there, and she had a big head bleed. So we're. I don't think. I think we did actually. I don't think she was. 100%, 100% right. So one of the other slides I didn't show in terms, but it was stroke. I mean, stroke patients, any alteration in their mentation, that's the key. Any change in their mentation warrants evaluation. Seizure could be, I mean, you're causing direct neurologic injury. Any seizure during stay in the hospital worsens outcome long-term too. So whether preventing it, stopping it, or anything like that makes a difference, no one knows. Prophylactic medications aren't indicated in any of those patients. If they are seizing, treat it. Traumatic brain injury, another population that is prophylactically treated, but even they will only give it level 2 recommendations for doing it, partially because there wasn't the ability to evaluate these people quickly. Now there is, at least you have some more information. Well, yeah, but you wouldn't be able to do a montage on them either. So, you know, you wouldn't be able to sit there and glue the thing on their head either. Yes, that's not who, again, that's not who we're talking about, right? We're talking there's an alteration there in some acute change. They present altered and they don't respond and improve, or they are here and then they change. My big argument for you, at least when you're trying to think what's the time frame, 1 hour. Yep. So if they present, give them an hour, no improvement, eval. You're having to pick and choose. If they have an alteration and you can't find something quickly to evaluate, check them then. If you're in the right unit that you have availability of it, just pull the trigger whenever you want to pull the trigger. Don't delay getting a CT scan for Cerebell, but it takes 5 minutes. So as you're packing them up, there's no reason why you couldn't get that information, right? You're not going to roll someone downstairs in VTAC. So why roll them downstairs for actively seizing? In 5 minutes is nothing in general time frame. So. Any questions online? Sorry, I went over. Okay. Thanks.